So think about that. If folks can get a cure for their disease, this can increase to 78 to 95%. So think about how much, and this is just kind of thinking about the economic, the dollars and cents that go back to our society. Just think about the richness of culture and the richness of each individual person that we're missing because of sickle cell disease. So, hemoglobinopathy therapies or therapies for sickle cell disease, hydroxyurea is probably the most helpful out of all of these, but the problem is it's not helpful for everybody. Some people grow out of it, some people it never works for, some people have side effects. There's been a lot of other medications that have come through the years, L-glutamine, crizanlizumab, voxelotor. Everybody's mileage with these vary. Some people do well, and a lot of times it doesn't make as much of a change as we would like. Transfusions and all the things that go along with transfusions, like iron chelation, and of course, pain medications. There's similar things for beta thalassemia as well. So I'd like to talk about what it would be nice to have a cure for sickle cell disease. And so let's talk about what's considered a cure. And functionally, I think for sickle cell disease, and what a lot of people would agree, is that it would eliminate or decrease the amount of vasoocclusion and end organ damage. So as you know, as we talked about, vasoocclusion causes all the pain episodes, all the strokes, all the priapism, all the other end organ damage that happens with sickle cell disease. So if we can reverse that, physical, mechanism, then I think we can often call that a cure for sickle cell disease. What does it hopefully do is it helps prevent a lot of these issues going forward. What it doesn't do, unfortunately, is fix a lot of the things that have happened already. So if people have had strokes, if people have had arteriovenous, avascular necrosis, if people have had other organ damage, it does not, as far as we know, it does not fix that. So in terms of the types of curative therapies, traditionally, bone marrow transplant was the only cure. However, it's been limited to only a few folks. So only about 15 to 20% of patients will have a suitable matched sibling donor. That means you have a brother and sister who is 8 out of 8 or 10 out of 10 match with you, and you only have it for each full sibling. You have a 1 in 4 chance. So that really cuts the number of folks who are eligible for bone marrow transplant down to quite a few number. There's always looking for an unrelated donor. There's always looking for a half-match donor, and there's issues with each of these, but oftentimes we aren't able to find a suitable donor. Graft versus host disease is also an issue with bone marrow transplant, and organ toxicity, and we'll talk a little bit about these things. So here are the basics of bone marrow transplant. And allogeneic is what we would use for sickle cell disease. So let's say this is a person with sickle cell disease. You need a donor, somebody with a healthy bone marrow, and it could be somebody with sickle trait, for example, like a sibling with sickle trait. In order for our patient to be able to accept and not reject the new bone marrow, we need to give conditioning, and this involves chemotherapy, sometimes radiation, sometimes combination of different things. So lots of different medications that basically wipes out the bone marrow. And then when the patient is in their most immunosuppressed state, then that's when we give them a stem cell infusion. And that stem cell comes from that donor. Those stem cells come from that donor. And it basically goes in through an IV or a central line. And it finds its way into the bone marrow. Then we wait. Those stem cells are kind of like seeds, and the conditioning, the chemotherapy we gave, that's kind of like tilling the soil. And so we're just waiting for those seeds to grow, and it takes about 3 to 4 weeks. And in the meantime, you're needing blood transfusions, patients needing platelet transfusions. They're at risk for all sorts of infections. They're at risk for dying of an infection or some type of organ damage as well. But as those new stem cells grow and make new red blood cells and new neutrophils, you start recovering. You start healing all those different things, mouth sores and all the organ damage and everything else. And you start being able to make red cells that don't have sickle cell disease in them. And that those red cells don't cause the same kind of damage that sickle cell cells do. And hopefully that leads to cure, and the outcomes are relatively good with this. If you have a match related donor, so a sibling, most likely that has a sibling that is a match. If you could do this early enough, especially when patients are in childhood, the overall survival is greater than 90 to 93%, 90 to 100% actually. The likelihood that it actually works and cures them of sickle cell disease is 84 to 100%. And there's something called graft versus host disease, where the patient has, if you have a new bone marrow inside you, and the new bone marrow is a new immune system, those cells, they realize that they're in the wrong place, and they can start fighting the patient and causing rashes and diarrhea and things like that we don't want. There is still a chance of chronic graft versus host disease, but they're relatively low. However, we always want them to be lower. And there's still a chance of dying as well. It gets worse if you don't have a match-related donor, if you have an unrelated donor, if you can only find cords and half matches. And so, especially in adults, the outcomes for adults are always going to be a little bit less than this. And so we've always been wanting to try to figure out how can we do this in a way that's less toxic, that's safer, and still gets the job done. We also have to think about who and when to transplant, and there's all these factors that we think about. How do your lungs work? How does your heart work? How does your liver work? If you have too many complications, then it makes it hard to do transplant. If you have too few complications, then you don't necessarily are eligible for transplant, because we always think about transplant as this risk-benefit ratio, where maybe your disease is not severe enough to need transplant. Of course, that's right now. We know that sickle cell disease is a progressive disease. There's all these other issues that come about. Then again, there's other factors that favor transplant. Let's say you do have a donor. Let's say hydroxyurea is not working for you. Let's say all these sorts of things are in the right place, and you really do need transplant. That really kind of narrows it down to just a few people that would be most suitable for transplant. And I think that's another reason why we need something else that's a little bit more safe, or fewer toxicity, and more available to more people. So this is allogenic transplant again. The thing that's different with gene therapy is that instead of having a donor, then the patient becomes a donor. And so the patient donates their stem cells, and this is done through stem cell collection. You have blood that goes through a machine. The machine filters it out and gives you back your blood, saves the stem cells. Those stem cells get sent to a company, and they do gene transfer or gene editing, and that basically fixes the stem cells so that they start making regular red blood cells. You still get the same kind of conditioning. It's a little bit more light compared to transplant because you don't have to worry about graft versus host disease. You don't have to worry as much about rejection. And then you have stem cell infusion. And of course, there's a waiting period between all these different things. You have to wait to get on the wait list to get the stem cells collected. You have to wait until the company is able to do the genetic modification, and then you wait for the stem cells to come back, come into the hospital. And it's the same recovery time, 3 to 4 weeks, and you have the same issues that we're dealing with bone marrow transplant. Hopefully, it's a little bit less, but or a little bit quicker anyway, and before recovery happens. And when recovery comes, then you have a new bone marrow that's making red blood cells that aren't sickle cells and that are able to act just like normal red blood cells. The benefits, of course, are that this does not have any graft versus host disease. You're getting back your own immune system. We got to still retrain that immune system, but you get your own immune system back, which is very advantageous. But of course, the things are, this is still pretty new. There's lots of waiting involved. It still has toxicities while we're waiting for recovery. And this I didn't mention with bone marrow transplant. Both of these, because they involve chemotherapy, they can affect fertility. And we'll talk a little bit about that. So I want to tell you a little bit about some of the gene therapy products that are coming out to a center near you. Beta cell is the first one that's for a hemoglobinopathy, first gene therapy that's now available, and it's now FDA approved. And I just want to show you, they treated 23 patients, and for beta thalassemia, the goal is to become transfusion independent, and 20 out of 22 patients were able to make normal red blood cells enough to become transfusion independent. And a lot of times they'll have hemoglobins, if they didn't get transfused, around 6 to 9 or so. And then if you after this gene therapy, after no transfusions, then they're starting to make hemoglobins around 12, which is amazing. The adverse events we talked about pretty much. So this is now FDA approved, which is super exciting. We're now a qualified treatment center for it, and we hope to start treating patients on it soon. For sickle cell disease, it's the same exact product from this company. They've decided to call it a different name called Lovocell. We don't know what the brand name is going to be. They treated 35 patients between ages 12 to 38. A lot of those patients were older than 18, so they're still enrolling and want to treat more kids. And we are a center for that. They only treated SS patients, S beta 0 and S beta plus. And this is reflective of Group C, which is kind of a modified manufacturing process. Here they were able to basically make folks into from sickle cell disease into sickle cell trait. So only less than half of their cells had hemoglobin S, and most of the hemoglobin in their system became regular hemoglobin A. More importantly, that hemoglobin A was distributed to a lot of the red blood cells, and that's really important in helping to decrease a lot of these complications. So this is the really the most important picture on here. This is each of the patients that was enrolled on this study, about what do we say, 35 patients. Each of the red dots, this is kind of a timeline of 24 months before they got the therapy. And and you can see the red dots, those count for severe vaso-occlusive episodes. So either they're in a hospital, they were in the ER, they got IV pain medications 2 days in a row, and some other things like that, or acute chest syndrome, or splenic sequestration, or priapism needing medical care. And so these are the red dots, and you can see over a 2-year period, it was pretty frequent in a lot of folks. The blue dots were kind of less severe crises that didn't involve those criteria. And so after the infusion of the gene therapy, then let's see, only 2 out of 35. So what's that? 33 out of 35 patients here were basically vaso-occlusive crisis free. And there are no severe vaso-occlusive crises among anybody, which is absolutely amazing. So just think about what life would be like that. These are some of the adverse events. We talked about all these things happening already. And what's important to know is that in the early manufacturing process, there were 2 patients that did develop some type of cancer in the bone marrow. So these used an old manufacturing process. They used lower cell doses. They had a lower amount of gene added to the cells. They used a bone marrow harvest instead of the peripheral blood stem cell collection, and they took a long time to recover. The gene therapy, unfortunately, did not work. So when they did the analysis, the gene therapy itself did not directly cause the blood cancer, but the fact that the gene therapy didn't take didn't probably cause the blood cancer. So that's why it's really important to get the chemotherapy to really wipe out all the old sickle cell disease, and then to make sure that the new manufacturing process works. A lot of improvements have happened, and those last 35 patients have all done very well in terms of this particular issue. And there's also an issue with anemia in some patients. And when they did the root cause analysis, they figured out that these 2 patients that developed anemia afterwards had too much alpha thalassemia in their genetics. So alpha thalassemia is relatively common in the sickle cell patients. A lot of folks have 1 deletion or two deletions. 1 deletion is okay for this gene therapy, but if you have 2 alpha gene deletions, then it actually can cause this anemia. So we continue to be a study site. Dr. Gupta is the principal investigator. We're still open to patients 5 to 17, but we're looking forward to Bluebird applying for FDA approval as of now, and hopefully we hear back from the FDA at the end of the year, and we'll be a qualified treatment center for this therapy. It's nice when there are competitors, though, and CRISPR Vertex is a competitor company, and they have their own product. This one works by turning off the hemoglobin, the fetal hemoglobin switch. So it just like hydroxyurea causes you to have more fetal hemoglobin, this one gives you more fetal hemoglobin in a different way, and it actually increases the hemoglobin F quite a bit, and it distributes the hemoglobin F in all the cells instead of some of the cells like hydroxyurea does. So they treated 44 thalassemia patients and 31 sickle cell disease patients. This is the thalassemia patients who are able to get their hemoglobins up to 12 to 14 without transfusions. Most of them were able to be transfusion free. More importantly, for sickle cell disease, you can see that the hemoglobin Fs were able to get above 40% for most patients. And that's compared to maybe 10% at best sometimes for hydroxyurea. So this is quite amazing. What is also really cool is seeing the outcomes after the gene therapy. 31 out of 31 patients were vaso-occlusive crisis free. So this company is also applying for FDA approval later this year, and it'll be nice to have potentially two competing companies in the market, that's more is better for all of us. We're also going to be now, these previous trials I talked about, they didn't look at SC patients, patients with hemoglobin SC sickle cell disease. Vertex is also is going to look at these patients, and they've opened up a trial. We are one of the sites, and we're going to be actively enrolling patients 12 to 35 with hemoglobin SC as well. So it'll be really exciting to see if this works well for that too. Editas is another competing company. They're behind the rest, but they've already treated their first few patients and have so far good results. It's all still very early. We have a clinical trial with them, but it's focused on thalassemia patients. Finally, Beam Therapeutics has kind of a new next generation therapy. They use base editing instead of some of the technology I was talking about before. We think it's going to be really a great therapy and very, very, very effective. The first patient was recently enrolled. It's a phase 1, so we're waiting to see how it goes for that first patient before enrolling more. Dr. Gupta is the principal investigator for this, and it is open for enrollment. And a lot of people are very excited about it and are very interested in it. It's 18 to 35 years old right now. Hopefully they'll expand the cohort later on. They're looking at the non-SE patients, so SS and S-beta thals. And these are the criteria they're looking for. So just to summarize, these are the curative therapies for hemoglobinopathies here at University of Minnesota. We have bone marrow transplant, otherwise known as hematopoietic cell transplant. We have protocols for sibling donors and matched and related and haplos. We also have the gene therapy. So we have the clinical trials I talked about, and also we're looking forward to offering the commercially available products when they're approved. This is kind of an overview of the process. We have a consultation, we review the diagnosis, we review complications that each patient has had, we optimize organ function, and we see which of these products is right for you. Then there's if we decide to do gene therapy, there's a wait list. The company will let us know when a patient can come for stem cell collection. Then there's stem cell collection, which we do inpatient 2 or 3 or 4 days. And send off the cells to the company each day so that they can manufacture. That's where the gene therapy product is made. There's a lot of quality control that happens. It takes several months. In the meantime, we're continuing to make sure all the organs are working well. And finally, then the big day comes, the cells come in from the company, and we start chemotherapy to try to wipe out the old sickle cell disease. This is the time where we're waiting for in the hospital for recovery, and afterwards there's a pretty strict monitoring period even outside the hospital, where we're doing daily clinic visits and monitoring very closely until we can space out visits. Then there's kind of long-term monitoring where we're checking every few months to make sure everything's okay. Other really important considerations, I always want to talk about fertility. So we know that these chemotherapies and sometimes the radiation that we use, this can affect fertility. Now, this isn't to say that folks that have had bone marrow transplant, like none of them, this isn't to say that none of them, this isn't to say that it's 100% that that folks will become infertile. We've definitely had patients have children after bone marrow transplant, but it's a significant possibility, and it really kind of depends on what your fertility was like going into it. So we want to be able to we work with our partners in the community and several potential grants from places to try to see if we can bank sperm for our men and boys, and try to freeze eggs for our girls and our women. So it's a significant process, but it's really important. And that's not doing it any justice. Mental health is a big part of this too. It's a huge change to think about not living with sickle cell disease. What to do about chronic pain is a big concern, and we because some patients that got the gene therapy, they didn't need their pain medications anymore, and they actually developed opioid withdrawal because they didn't need their pain medications. So we need to work with our chronic pain colleagues to help with that, and financial toxicity. And so we don't know the clinical trials, a lot of this stuff will get paid for, but you still need to worry about having a caregiver and having that social support for these commercial products. I mean, these companies are charging more than a couple of $1 million for each of these treatments, and hopefully we get insurance to pay for these things. And we've and I know that Ray has been advocating to our state and other states about coverage for these treatments, and that's so important. But there's so many other things that go along with it. So these are so important. I just can't do them justice with the period I have. So if we can address a lot of these issues, the balance toward curative treatment could be shifted, and hopefully we'll be able to really expand the number of folks that we can cure of sickle cell disease and thalassemia. This is kind of a nice patient quote that I saw from, I think, the New Yorker magazine. After the therapy, Gray felt as though she'd been cured. She hadn't been hospitalized in more than 2 years and needs no pain medications. I don't feel like I have sickle cell at all. I work full time. I enjoy my kids. I don't have to worry I'm going to end up in an emergency room when the weather changes. I'm not tired and drowsy from taking all these narcotics. I can make plans, just regular plans, to go on vacation, to do things with my kids without fear that it will bring everyone down by starting off with a good day and then starting hurting and have a crisis. Gray began to tear up and her voice cracked. I can do all the things I always wished and dreamed that I could one day do, she said. So this is certainly not something that I can do, and not something that Ashish Gupta can do all by ourselves. We have a huge team, including our hematologists at the University of Minnesota and around the whole Twin Cities and in the upper Midwest, who we meet with regularly. And our social workers, Ray has been amazing from the Sickle Cell Foundation of Minnesota, and many other resources at the University of Minnesota. So thank you so much. Yeah, happy to take questions and sharing.
That is so fabulous. There's so many things going on in the community and in the science of curative therapies. Now, we do have a few questions that have come through. I want to bring Dr. Ashish Gupta into the conversation here as we continue along. I think it's pretty cool, Dr. Cal, that you have done peds hematology and now you're in adults. I think that there's something to be said for having an understanding of these families across the lifespan. That's really helpful. Dr. Gupta, you are totally enmeshed in the pediatric world. And what I am so incredibly impressed with is, I've been doing this in the sickle cell community and been an advocate and been in this space for a very long time. And it's only in the past few years that I've seen as many kids getting cured that I have in the state of Minnesota. And it's incredibly exciting. And so much of it is because of the work that you're doing. Can you talk a little bit about that there at the University of Minnesota? And what makes it different? Why now are we able to step up the number of kiddos getting cured, or at least getting this treatment?
Sure. And Ray, I don't take the credit for this. This is, as Dr. Kao mentioned, it is a whole team, and it's a process. And I think when like-minded people are aligned, like yourself and many more working in the field, things do happen. As you know, Ray, we are in a very interesting territory, as we, especially for sickle cell disease. Upper Midwest is a completely different territory as compared to Virginia or Florida or Texas or Tennessee. We are sitting in a center where, like, especially on the pediatric side, we do have small population of sickle cell patients here, but we have a children's hospital across where there is a comprehensive sickle cell center. And like, as you know, between the institutions, like there has to be a collaboration to see these patients. We actually went on to build a collaboration beyond that, which was actually spread all across the Midwest. We brought the centers together. We share a platform where these issues can be discussed, the medical complications, the sickle cell related issues. And what was very important for us, especially at University of Minnesota, was we have a long-standing transplant history. We know transplants in and out, to be honest. We have contributed so much to the transplant world that transplant was less of an issue. The issue was bringing the community together and having that platform and understanding the disease where we can actually transplant these kids successfully. And I think over the past few years, that has been, I would say, our biggest achievement in connecting these communities together, in connecting these providers together, and addressing it very openly and very transparently. Who is eligible for a transplant? Who should be considered for a transplant? And also having those hard conversations where we do feel at times that transplant is not in favor of a patient, which is an important decision to make. Transplant has its own cost, not the financial cost, not just the financial cost, I should say. It is a life-saving therapy, but at the same time, there are complications that are life-threatening as well. So it's a very, very important and very cautious decisions that need to be made. And as Dr. Kao beautifully showed in his presentation, that the risk and the benefits, that balance is the most important thing to consider. As some of the questions that were coming up in the chat was about the donor and the indications for transplant, and I kind of like it goes across for other therapies as well. It actually like weighs a lot on us what kind of donor is there. So for example, if there is a fully matched sibling donor, you really don't need indications then. In those situations, American Society of Hematology, ASH, which is the largest body in North America of hematologists, they recommend actually you can go for transplant as early as 2 years of age. And that is because the matched sibling donor transplants are like one of the least risky transplants, and the potential benefits there outweigh the risks that we are taking with transplant. So it is a very different story than comparing a half-matched, or what we call as a haplotransplant, or a mismatched unrelated donor transplant, which comes with much more chemotherapy, much more risk of toxicity, and also the risk of graft versus host disease and risk of graft failure. So each of these situations need to be considered. There has been successes with even half-matched transplant and unrelated donor transplant. But again, this is an evolving field. This needs to be very carefully considered when we are in those situations.
So, I mean, you said such a mouthful, right? And one of the things that I'm glad that you brought up is really the psychosocial pieces of this journey. I think that, I have a son that's 26 years old that is living with sickle cell disease. I have many friends who have gone through the bone marrow transplant journey. I have a couple of friends who are participating in the clinical trial for gene therapy. So there's so many things on the horizon. And I think back to even my time in working in the pediatric clinical setting and the conversations that I would have with families. As you both know, I say it all the time, knowledge is power, and the absence of knowledge really leads to oppression. And so having these open conversations, being able to talk about, what makes what really makes a good patient that is ready for this journey is truly more than just the medical indications, but yet it's the medical indications that really drive if a person is eligible and if they are a good candidate. That's a huge piece. And what I've noticed is that the older that you are, those criteria become a little bit tighter, right? I worry about our young adults and adults who are still eligible for some of these new treatments that are coming out, but have suffered so much organ damage along the way. Do you feel like that is going to be addressed? Because I feel like it's going to be such a limitation. We know that there's not enough hematologists, in North America, even, let alone the world. But even the other specialists, organ specialists that may not fully understand sickle cell, that may be kind of inching along in their care of a person with sickle cell. How do we change that so that, when this becomes readily available to everyone, not only will it be affordable, but that we will make sure that, people's organs are in a condition that they're not going to be turned away because they've had to live with the disease. And now they're in a position to not be able to get the cure because of the damage that it did. Dr. Cal, maybe you could speak to that.
Oh my gosh, right. Amen. This is what we deal with every day as adult sickle cell doctors, that we see organ dysfunction as folks get older. And we wish that we could have told all our pediatric patients about what happens. I think part of what gene therapy was meant to address was to try to do this whole process a little bit less toxic. The issue is that it still involves a lot of chemotherapy, or the 4 days of chemotherapy to really wipe out that old bone marrow, and that those 4 days of chemotherapy, and then of course the 3 weeks of recovery afterwards, it really puts your body through a stress test. And so if your organs aren't working very well, then that really makes it makes it a lot harder to get through. Basically, the issue is also that the clinical trials were based on patients that didn't have a lot of these organ issues, and so these are not a lot. I kind of always think about, these are hand-picked patients that got the gene therapy. These patients had the best care. They had they didn't have a lot of the same organ issues. So how do we translate gene therapy so that it works for the rest of everybody? I think that's one of the biggest questions that I have. Can we use gene therapy for people with stroke, for example? It was not on the clinical trial criteria that anybody that had a stroke could get gene therapy. And so what's going to happen with those patients if we use gene therapy? What happens with adults with other issues? Can we use we use some, there's plenty of different options that people use for the chemotherapy process before transplant. can we use those for gene therapy as well? And so these are really big issues that the whole field needs to answer, and hopefully we'll be able to work with others to try to answer those questions.
Ray,
Yep.
sorry, Ray, I will also add one thing I think which is extremely important here. As you mentioned that when the patients are in that young adulthood or later, like the organ damage is there, and it is a reality. And as Dr. Cow mentioned, this is more of a progressive disease. So what it actually stresses upon is that we should start thinking, and we should be doing this, especially the education piece, more towards the pediatric side. Like, this is where this conversation needs to start. A very beautiful chart that Dr. Cow showed was the increase in the risk and the dropping benefits of this. What we have learned the hard way, and we have developed here, at least in Minnesota, is that our referrals, when they come to us, like they might not be, most of them are not like eligible for a transplant or a curative therapy at that point. And that is okay. But we do not leave it at that. Like, every few months, we regroup and see where the kid is, because that ongoing evaluation is extremely important. And also, it's an ongoing education actually for the family, and looking into the whole, like, a psychosocial aspect of the patient. It is extremely important that those conversations start early enough. This is a changing field. This is an evolving field. Like, me and Dr. Cow see these results being updated almost every month, actually, from gene therapies or from transplant outcomes. So I think this is key, that the education has to be ongoing and needs to be initiated pretty early during this journey, so that, like, providers like us also can actually assess the patient in the long run, and also find that optimum time and the appropriate time when these curative therapies or transformative therapies, whatever you want to call it, are introduced actually at really the right time for the patient and the family.
I'm really glad that you said that, because that's, that was one of my biggest hangups, is that why does a person need to wait until, they are what I always call on fire before we start to look at this as an option? How helpful would it be if during those younger years, while your child is still small, you're beginning the learning process? You might not be eligible when your child is 2, or your child may not be eligible when they're 2. They may not be eligible when they're 6. But what if by the time they're 18, 19, 20, what if that becomes really a necessary step to take? Or because of medical science growing, now there's more options. I think what makes me nervous is, presenting the curative therapy option to families when they are in their most stressed out situation, when they're in a dire situation, when themselves or their child is their back is against the wall. That's not a great time to have to make such a huge decision. And so when you have this gradual learning that starts with the early education, I actually think you can make better decisions, but you have a better understanding as well. Now, you said something, because you called it transformative versus curative. We hear so many terms in the community that I think it can be very confusing, particularly those who are just beginning their roller coaster ride in the sickle cell community. What's the difference between a curative, transformative therapy? How are we differentiating here, and why do we need to differentiate?
That's an excellent question, Ray. And as you know, this is all is in the eyes of the beholder, right? I mean, it is having a child free of vaso-occlusive crisis is good enough a cure for someone, versus getting rid of the disease completely might be the goal for someone else. So it's there are some semantics there, but with cure, even with transplant, honestly, we are not uprooting the whole sickle cell from the genes, from every single gene of the body, right? What we are transforming is essentially the hematopoietic system or the blood system of someone, which is definitely something which is responsible for most of the complications. I often have been asked this question by the families that when my child like even after transplant, when my child grows up, do they have to meet with a genetic counselor, or like do they need to think about who they are marrying, and do they have to have the counseling from sickle cell? And the answer is yes, because you are still carrying the SS in your reproductive organs, and that is what is going to be passed, and you have to think accordingly. So the discussion regarding the cure or the functional cure or the transformative cure is important, and I think these therapies, especially the newer therapies like the gene therapy, and the way they work is very different. And I think the context is important, but also um, I think what is more important is to see what effect they are producing. If they are able to cure vaso-occlusive crisis, that is great. Can they be able to prevent future strokes? Maybe, maybe not. Right? I mean, that those things are still like to be seen. Those things are still where people have not, like, I mean, these trials have not evaluated those aspects. So there's a lot to learn, but at the same time, I think that is what goes into our risk benefit evaluation as well, as providers who offer these therapies, that we counsel the families and we provide that education to the families, that what are the expectations out of this. This is there's not a moonshot yet. We are, again, like, this is a big hope, and this is a big move towards that moonshot, but there's a long way to go.
This has been a journey. This is not an overnight, and frankly, we don't want it to be overnight, right? Part of the reason that the reason clinical trials exist is to ensure that it is a safe product for the general public. It's also the reason that there are guidelines about who qualifies and who makes a good candidate and who might not be a good candidate. And so, sometimes we think about, clinical trials in the sense of guinea pigs, right? And I think that it's worthy to validate that we've come a long way in our history in how clinical trials are done, and the ethical way that they are done versus the way that they used to be done. So I think that it's important to understand, so that people understand their rights during a clinical trial and during that process. So thank you for bringing that up. I want to go to the questions because I want to be cognizant of the time. And I know there's a couple of questions that we've addressed, but I'm going to talk about the big elephant in the room. All of these treatments and therapies are great, but I'm concerned that they're going to be so expensive, so cost prohibitive, that they will be beyond the reach of many, particularly those, which is most, who have public insurance. We hear on the news already about, the cost associated with, healthcare in this country, and, so many people who beyond any choice of theirs need public assistance in order to get the care that they need and deserve. But now we're talking about therapies and treatments that are, millions of dollars. How are we going to do that? What needs to be changed? What do we need to do differently to make sure that this is available to the average person?
That is, again, an excellent question, Ray. And, it is a very phenomenal era that I think we are practicing in and we are living in, to be honest. So thalassemia gene therapy, when it came, and Bluebird Bio is the sponsor for that one, when it was FDA approved, the price tag to that is about $3 million. What we have heard for sickle cell, and again, there are two companies that will be or are applying for license, actually, and we are hoping, depending on how FDA evaluates the license and the labeling. But what we have heard is that the price tag for that would be around $2 million. So there's a 33% discount, but it is no way a reasonable therapy if you think in terms of cost. A transplant as such, if you have to pay out of pocket, it is about like a $700,000-$800,000 therapy. So these are expensive, no doubt about that. I think what is going to bring down the cost is definitely the competition. as there are more options
point.
available in the market. And we see that in sickle cell world very clearly. For thalassemia, there is no other competition right now. There is another therapy for adrenoleukodystrophy. There is no other competition right now, but definitely that will define the market. But also having more players in the market actually gives that extra push to sit down with the insurance companies and discuss these therapies, discuss how the coverage is going to be. And there is a lot of activity in that space. As Ray, you are very well aware that how these different companies have been working along with a lot of insurance companies to get it approved in their domain. Now, thalassemia and other gene therapies that are approved are not as, the numbers are not as much in the US as we talk about sickle cell. And how much it is going to be covered, what patients would they be covering, all that it will be, I think that is to be seen, and how FDA actually regulates that therapy will be important to see. But yes, it is an ongoing discussion. It is something that healthcare systems are aware of, and has been discussed quite a bit in the healthcare system world and insurance companies. So
yeah, no, I'm glad that we're talking about that while, these clinical trials are still going on there. And make no mistake, there are conversations. I always say there's conversations in the boardroom, the back room, and the emergency room. The conversations are happening. What happens is it doesn't always trickle into the community. So that's why I love having our SickleSMART show, because, we talk about the things that, I might hear at a meeting, I might hear, in some of the work that I do in advocacy, that we need to be having this conversation out loud. We know that, a couple of years ago, Bluebird had to pause their trial because of concerns, around cancer. We know that there have been changes in the way that they are doing the actual therapies, so that they can eliminate, some of those risk factors. And so we're really thankful that this process exists the way that it does, so that, as I said earlier, we can be sure that it's safe for everyone. I also know, that something that I actually just learned probably only about a year ago, we talk a lot about gene therapy being gene deletion. So, right, there was always those scissors that cut it out, but now they actually have gene addition as well. And so there's so many things that are cutting edge and on the line for medical science. But what's the timeline? I mean, you have parents who, have other children. I've actually walked with someone through their kind of transplant exploration, and they couldn't get a transplant because they didn't have a caregiver that was going to be able to be with them. That's just a horrible reason to not be able to get the cure. So, what is the amount of time that it takes? How long do you have to be in the hospital and away from friends and family and protecting, yourself? Obviously, there's a difference between BMT or bone marrow transplant and gene therapy, but can one of you speak to that a bit?
Sure. Roy, do you want to take that one? I'm happy.
Yeah, sure. I think so I think one of the questions is, between the time that you decide to do gene therapy and the time that it actually happens, there's a lot of waiting in between. And so you're waiting to get put on the wait list. You're waiting to come off the wait list. You're waiting to get the and that can be several months, especially for these clinical trials. They're making sure that the first patient gets the gene therapy, does fine with it, and then so they can move on to the second patient, and they could make sure that they're doing okay as well. So this is how some of the clinical trials work. And then there's also the capacity for some of these commercial therapies as well. So they're probably going to be able to make only enough for one patient every week, or two patients every week, or something like that. So who knows how long that will take. So I want to kind of set those expectations that it could be a while, but hopefully as it gets better, then it's a little bit faster. The part that's most significant is that time in the hospital. and then the first couple of months afterwards. And so that time in the hospital is probably about 4 or 5 weeks, including the week for chemotherapy, the day for infusion, and then all the weeks afterwards for recovery. So that's a significant time commitment. And then afterwards, there's the daily visits to clinic to make sure you don't need a blood transfusion, don't you need extra fluids, make sure all the medications are all right. So there's a significant amount of care that happens afterwards to make sure that this works, and that you don't get a lot of the potential problems that can happen if things aren't being paid attention to. But yeah, that's why the caregiver requirement has been part of transplant at University of Minnesota for such a long time, is that we want to make sure that you have somebody that can to bring it to appointments, to call 911 if something's going wrong. So all those things are kind of important, but at the same time, I see lots of my patients, and not just sickle cell patients. Lots of my patients are not able to have a very stable caregiver like some others. So this is something that is, we need to do better as a society.
Yeah, I mean, I agree. And what I hope is that we get a network, together of people that can support those who are going through this journey, who may not have, those that support system, or a parent who can take that much time off of work, right? You still have to care for the other children. You still have to pay your costs of living and things like that. So, we have to think outside the box. Really, this is about thinking outside the box. These are expensive procedures, and it is important that you have someone that's with you and caring for you. So, we all have to put our heads together and figure out, how do we make this work best for patients and families. There is another question about organ damage, and that'll be the last question, because I want to end with my final question. But organ damage. So, and I think part of what this person is saying is what we hit on earlier, addressing, the organ protection early in childhood, right? So that by the time as they age, they have less progressive damage. We know that hydroxyurea exists, that works for so many, yet we know that there are those that it may not work for, or may not choose to go in that direction. I'll just give my personal journey with hydroxyurea. It was transformative in our lives. It went from, my son being in the hospital, what felt like more time that he was there than he was at home during the first 5, 6, 7 years of his life. And when he went on hydroxyurea, he was only like the second or third child in the state to be on hydroxyurea. And it absolutely changed the way that his sickle cell showed up. No, it didn't cure him. No, it didn't eliminate every single complication or pain crisis, but it definitely lessened it by absolutely more than half. And that was significant for his quality of life, my ability to be a caregiver, providing quality of life to him and our household. So I think that having that conversation earlier on, being aware of those things, helping your child in an age appropriate way to be aware of it and how they take care of themselves, is part of that conversation. But it is part of having making sure that the pediatric environment kind of has this buy-in and understanding why it's important to have these conversations in a proactive way, and not in a reactive way. And I think that really addresses a lot of these conversations that aren't happening. Sometimes it's avoidance. Sometimes it doesn't seem appropriate. I am of the mindset that you give people the information and let them decide, what's best for them and how to proceed. So anything to add to that?
Ray, you nailed it, to be honest, that this is a very important conversation. And again, going back to having these early conversations on the pediatric side is extremely important. As we know that as kids continue to progress into their adolescence and then the young adulthood, it becomes it becomes more and more clear that yes, there is some progressive organ damage, and to prevent it, we do advocate that you need to consider some of the curative therapies sooner than later. And again, like different kids have different course, as we know. Even with the same hemoglobin SS disease, it is not that two children are going to have exactly the same course. So that is where, again, like I go back to the same advice about risk versus benefits, and that is where the role of a hematologist and a transplanter becomes extremely important, to see where the course is going, to understand what the disease status is, and see what are our options, put everything on the table, have a very honest and very transparent discussion with the family. And if the patient is at that age, that they can be involved in the discussion, because it's important. Like the chemotherapy is not a small thing. It is also something that can damage the organs, can have long-term effects. There are children, unfortunately, and adults who go through this therapy and do not make it to the other side. It is unfortunately the reality. The outcomes have improved significantly in the last 10 years, but again, we are not at 100% success rate yet. We are closer to that in the massive donor transplants, but still there's a lot of room to grow there. So again, those conversations, understanding the therapies, understanding how it works, and also understanding this changing world where there are other options, there are clinical trials coming up, and there are ongoing evaluations for these therapies. All those discussions are extremely important.
Thank you for saying that. And just in respect of time, I want to let people know that I did add a couple of links in the chat box. So we have an amazing community organization called Sickle. Let's see, I got to get it right. The Sickle Cell Reproductive Health Initiative Health Education Directive, Sickle Cell Red, so SC Red, and it is head up. Co-founded by Tiana Wolfer, who is a warrior in our community. She actually underwent a bone marrow transplant many years ago that was not successful, and a big issue was was the loss of her ability to reproduce. And so now she has this organization that addresses those things. And so it is important that we talk about, those side effects and things that we can address beforehand and not after. I'm glad that we are having those conversations, and I'm glad it's on you all's radar, because part of the benefit to getting a curative therapy is to be able to improve your quality of life, and for many that includes having a family. And so we are also working on funding for that. There's disparities in the funding, guys. We want you to know that we recognize that there are conditions where there are certain things that are covered for one condition that are not being covered for sickle cell disease. And trust me when I say we are fighting behind the scenes to address that, because that is not equitable, and it is not acceptable. And we have to make sure that all communities have access to the same resources that are available to contribute to their quality of life. We have a couple of people in the chat who have had a child or children go through a curative therapy, and we celebrate that. We also keep in mind those who did not make it through their journey, and so we honor those warriors who have gotten their wings, and those family members who are left behind thinking about these things and watching medical science grow from the time that their child may have experienced it. So I never like to leave this space without acknowledging, the various journeys. I love that I see, a college freshman who and who is thinking about her journey ahead with getting a cure so that she can go on to become a veterinarian. Like, these are the things that are so meaningful to why these therapies and treatments are so important. We have big dreams. I think that there has been a very sadly attached narrative, that we just sit back and take this sickle cell and we just accept it for what it is. That couldn't be furthest from the truth. We call the sickle cell community, we call them warriors because of that fight that's in them, because of that persistence that's there, because they still hold on to some level of hope in spite of the challenges that this condition brings. And in spite of, y'all know I say it out loud, in spite of living in Black and brown bodies that already creates a very difficult environment. And so I am grateful to be able to say that Dr. Gupta, Dr. Kao are part of our Minnesota sickle cell family. I consider them both friends. So many of the things that we discussed here, we talk about, we put it on the table and we say, hey, this is a problem. Hey, I'm concerned about this in the community. Hey, we're not having enough conversations over here in pediatrics. Hey, how are we talking about life after, transplant? That's an entirely new existence that you didn't know. Our kids were born into sickle cell disease. They didn't know a life without it. And then once you get a transplant, life changes. We also have to talk about, as you pointed out, some of those, some of the complications that have occurred in the body prior to the transplant are still there afterward. Where do they go to seek help? Do they still go to the hematologist? What do they do if they have to go to the emergency room and they don't know what to do with them and they don't have sickle cell? Like, we have to be having all of the conversation and not just pieces of the conversation. So we could never exhaust everything. This is just the beginning. This is just another spoke in the wheel in this conversation. We really hope that you've taken something from this, that you've learned something. And if nothing else, that you came away with more questions that you can talk to your medical team about. Most of you, many of you are part of larger medical systems with some amazing hematologists and transplant physicians. But if ever you want to reach out and you're looking to connect to someone that you can talk to and ask these questions, maybe you don't have access to that, by all means, please reach out to us. Did I put our website? If I didn't put our website in the chat, we are at SickleCellMN.org. That's SickleCellMN for Minnesota.org. And so we always invite you to join us there. Any departing words before we conclude, gentlemen?
Keep up the fight, Ray. You're doing an amazing job there, and all the people who are involved in this journey. Like, again, it takes all of us to change this to fight a disease like this. So, and I'm so glad that we have this ongoing collaboration, and that is the only way to fight this.
Absolutely,
Amen.
Dr. Kao.
I think thank you so much for all that you do. Thank you to everybody for all your attention during this talk. There is so much more to talk about, especially what happens after transplant and that happens after gene therapy. But I think you'll just have to have us more often, Ray.
I will. And I just cannot end today without saying today is actually National DNA Day. So for those who don't know, this month marks the 20th year anniversary of the completion of the Human Genome Project. That project really launched so much of where we're at today because of our understanding of the cellular life of the human body, right? And who we are. And so I have to point that out because, sometimes we shy away from some of this science stuff and we have many questions, but we also have to celebrate the advancements that get us to the cure that we're looking for. So I'm so grateful for that. There's many more trials opening, many new drugs in the pipeline. I do want to make sure that I absolutely thank our special guest presenters, Dr. Roy Kao and Dr. Ashish Gupta. Gosh, you guys make this work just that much easier. We all know it's hard work nonetheless, but it's great to be a part of a good team. Also, if you are interested in future SickleSMART sessions, you can learn more about it on our website, SickleCellMN.org/SickleSMART. Or you can also sign up for our future events through Eventbrite, and you can actually be notified when we post new events. You can follow us on social media. Also, we always post about upcoming activities and events there as well. We love the fact that every single session we upload to our YouTube channel. So if you missed parts of this or you want to see it again, give us a couple of days and it will be on our YouTube channel. If you subscribe to the channel, make sure you click that little bell so that way you will actually be notified when we do upload something new. And we're up to probably, maybe 60 or so videos from over the years that we've done in the last few years. And we have everything from navigating primary care to why Black blood matters in donor diversity and blood donations. It's a pleasure to be able to do this in the community and to provide this education. And then lastly, our virtual activities that we have each and every month is our Sickle Cell community-wide support and empowerment group. That is for caregivers and warriors ages 16 and up. We have a Ask Dr. Nelson, which is our monthly town hall session that we do right before our support group. And that is, again, open to the public. Both of those happen on the last Thursday of every month, so join us. And then this month, we just started our More Than Sickle Cell community conversation with Biba Tinga, who is the executive director of Sickle Cell Disease Association of Canada. So we are having lots of great open dialogues and conversation. We invite you to be a part of it. Like I said, you can visit us on our website, take a look at our calendar, or you can just sign up at Eventbrite and follow us through there. Let's see. I can tell you that we have a session coming up in May on priapism. Oh my goodness, one of the most under-discussed topics about complications in sickle cell disease. And we've got a male warrior who unapologetically speaks up and talks about his program called Save Our Male Trunks. Don't you just love that title, that name? I love it. So Demetrius Wyatt will be here, and I'm excited to have that on May 30th. If you are local, we have our annual slow roll for sickle cell coming up on Saturday, June 3rd. Join us. It's a slow roll bike ride. We have a long bike ride for people who like to take long bike rides, and I think it's like 30 miles. That is not me. I will not be on that bike ride, but we do have a shorter one that's like 1 to 2 miles, and it goes at a much slower pace. You don't have to have a bike. There are bikes that we make available as well as helmets. So bring your whole family. That is being offered. You can go to our Eventbrite and you'll find that as well. And don't forget, I kind of mentioned it, donate blood. We always need more blood. We always need diverse blood. So it's important that those of us in the community that understand the need for blood and have had children and loved ones who've received blood, let's do a little bit more to encourage our friends and family and workmates to donate blood as well. We really do need it, y'all. All right. We talked a little bit about bone marrow transplant and as well as gene therapy. Be the Match is a bone marrow registry. Much like donating blood, we need more diverse donors. It should not be that certain groups, if they are looking in the registry for a match, that they have a better chance than others. But if it's for us, it has to be with us. We're the us, y'all. We're the us. Us's. We have to also be part of that registry. Have a bone marrow registry drive. Get everybody, get your church, get whomever you can, but we have to do better. We have to make sure that there's more representation on that registry. So please be a part of that. And then we also have Our Voices Matter. That is our way of tracking what are the good things and the not so good things happening in the community around your medical experiences. No, we don't share your name, but what we want is those real life experiences that we can help when we're sitting at those tables of influence, and we can have conversations about what kind of things need to change, what policies need to be addressed. The best way to do it is to have your lived experience stories at our fingertips so that we have real examples. So you can find more about that on our website as well. And that wraps it up for another Living SickleSMART. We're glad that you joined us. Thank you, Dr. Kyle. Thank you, Dr. Gupta. And thank you, each one of you that joined us. We're so appreciative, and we'll see you next time. Signing off.
Thanks.
Gentlemen, can you stay on for just a moment?
Sure.
Thanks.